On behalf of the Duke Margolis Center for Health Policy, I would like to welcome everyone and thank you for attending this webinar on leveraging payment reforms to transform and expand home-based care for people with complex health needs. As many of you know, we've seen a substantial shift over the past 2 decades to more care at home and in the community for people with complex health needs. The pandemic has accelerated that shift, but still today, the home setting used for care is uneven and underutilized. Despite evidence indicating overwhelming patient preference for home-based care to a much greater extent than it is today, there are an estimated 7 million Americans that have been unable to set up routine use of home-based care or have difficulty in doing so due to their complex medical and social needs and the supports available in their community. There's a mismatch between the demand for home-based care services and the current level of care provided, and this gap disproportionately affects communities and individuals that have been economically and socially marginalized. This is an issue that is becoming more pressing as the US population continues to age. Now, many payment reform initiatives, pilots, demonstrations have been implemented to support this shift to home-based care, taking advantage of developments in technology, remote monitoring, and experience of the care models to date. This includes a variety of innovative care and payment models that enable Medicaid and Medicare reimbursement and support for services to move with patients into the home. At the same time, the variety of home-based care delivery models and the heterogeneity of individual needs makes it challenging to develop payment approaches that can scale and expand across these diverse circumstances, meeting patients' complex needs without increasing total costs of care, doing so in a way that builds on opportunities to learn and scale. So the models need to balance flexibility in providing appropriate services, ideally assuring that the patient's whole spectrum of needs can be addressed effectively. And that requires accountability for health outcomes, accountability for total spending, new capabilities and infrastructure to support the care models. And this is an issue that many of us here today have been involved with for what seems like a really long time, given the urgency of the issue and the opportunities. But now, today, also seems like a particularly opportune time to consider how to close the gap through aligned care reform and payment reforms for patients with diverse, complex needs. First, the pandemic has significantly changed how and where care can be delivered and expectations about care delivery, accelerating the shift to home-based care and advancing virtual care and community-based supports. At the same time, CMS has highlighted its agency-wide commitment to providing access to comprehensive, coordinated care for all Medicare beneficiaries and Medicaid beneficiaries, particularly those with complex needs. CMMI is strategically evaluating its portfolio of models to accomplish this goal as effectively and quickly as possible, with a particular emphasis on models that support comprehensive care for beneficiaries with complex needs, and a particular emphasis on models that address inequities and disparities in health and healthcare. So now is a great time to consider what has worked well, what hasn't, and what are the best approaches and innovations for this next phase of policy initiatives to advance the shift to home-based care, to sustain these promising models and scale them going forward for effective access to home-based care across the population of Medicare beneficiaries, Medicaid beneficiaries, really all Americans who could benefit. To take advantage of this unique policy window, the Duke Margolis Center has been reviewing the evidence informed by a range of expert and stakeholder perspectives to develop updated recommendations for achieving high-value comprehensive care for individuals receiving care in the home setting. And in today's session, we're going to start off by providing some insights into our project's high-level focus, some of our findings to date. Then we're going to hear from a diverse group of stakeholders and experts who have been hands-on with efforts on opportunities to expand home-based care through value-based payment models. Then we're going to conclude the webinar with a very special guest, a conversation with the CMS Innovation Center's Chris Ritter, who oversees many of the models in this space, on the topic of pathways to drive innovation effectively from here. So great lineup for today. And I want to start off by thanking those who have made it possible. This project and the webinar today are supported by the Commonwealth Fund, the SCAN Foundation, and the John A. Hartford Foundation. And on behalf of those foundations, I'd particularly like to thank their leaders who are with us today. Ronny Snyder, who's Vice President for Programs at the John A. Hartford Foundation, Gretchen Alonzo, who's Vice President for Policy and Communications at the SCAN Foundation, and Karin Lewis, who's Program Officer for Delivery System Reform at the Commonwealth Fund. I'd like to turn to each of you for some brief opening remarks to help us get going. And Ronny, can I start with you?
You bet you can. Thank you so much, Mark. I love the way you framed that up about thinking about closing the gap between care and payment for home-based care. So I am Ronny Snyder. I am Vice President of Program at the John A. Hartford Foundation, as Mark said, and we're really pleased to be supporting the Duke Margolis Center for Health Policy and the work that we're talking about today to expand home-based care for people with really complex health and social needs. We at the Foundation are supporters of the work of Duke Margolis on home-based care, and also together with our very close friends, they're more than partners, they're friends of ours at the Commonwealth Fund and the SCAN Foundation, who you're going to hear from next. Our three organizations are part of a collaborative of 7 funders, all of us together seeking to improve complex care. So today's webinar, plus the issue briefs from the really terrific Duke Margolis team, which I hope you've seen, and the convening and policy dialogue about home-based care that they're facilitating are really incredibly important to our collaborative and to also to our mission, our foundation mission at the John A. Hartford Foundation and the population that we serve, which is older adults. So just a line on the foundation, we are a national philanthropy. We're based in New York City, and our mission is to improve the care of older adults. So we work in 3 priority areas to do that. Creating age-friendly health systems, supporting family caregivers, and improving serious illness and end of life. And in all of those areas, and especially as we promote age-friendly care for older people, home care is really essential. And why is that? Well, because age-friendly care is about reliably using the evidence-based practices and focusing on what matters to most of us as we get older. And so for so many of us, what matters a lot is home, where the people and the things that are most important to us often are. So we know home can be safer and a more effective alternative to inpatient care for a lot of conditions, which is why we at the John A. Hartford Foundation support programs like hospital at home and rehab at home. In addition, millions of people with really complex conditions are homebound or face a lot of challenges when trying to leave their homes, which is why we support home-based primary care and palliative care. And that makes a lot of sense to us. So getting home-based care to all of those who can benefit is going to take the kind of policy action at the state and the federal levels, which is why I'm super excited to hear today's discussion from this really outstanding panel. So we hope everybody will continue the discussion that is started today with your own research and advocacy and systems improvement. And we hope that you will check us out at the John A. Hartford Foundation and take a look for resources at the Better Care Playbook. It's bettercareplaybook.org. This is a project from the 7 funders, the others of whom you'll hear today, on complex care that has resources that are there for adopting home-based care models and other models. So that's it from me. Thank you again, Mark, and I will turn it over to Gretchen.
Wonderful. Thank you so much, Mark. Thank you, Ronny, for your great remarks. We're just so pleased to be part of this. My name is Gretchen Alonzo, and I serve as Vice President of Policy and Communications at the SCAN Foundation. We're an independent public charity in Long Beach, California, focused on transforming care for older adults in ways that allow them to live well in the place that they call home. When we think about the COVID-19 pandemic, it has upended the human experience across the globe, touching every aspect of daily life, particularly for older adults, those living with complex care needs, and their family caregivers across the diversity spectrum. Early on, federal officials at the Center for Medicare and Medicaid Services gave states and local providers substantial flexibility on how care could be organized and delivered during this public health emergency. We at the SCAN Foundation have funded several organizations to capture and learn from these wide-ranging flexibilities in health and long-term care delivery, as well as the payment that supports them. The goal for gathering this information is to help shape and adopt new ways of delivering services that amplify person-centeredness based on consumers' needs, values, and preferences going forward. We are really pleased to partner with the Duke Margolis team and our foundation colleagues to focus on transformational ways to expand home-based care for people with complex health and care needs that meet this person-centeredness test. So one of those big aspects of those flexibilities being the conversation we're having today. No one knows how long this public health emergency is going to last or its ultimate substantial effects and devastation. However, leaders right now are able to use this difficult period to accelerate models that address people's needs in this changing environment, evaluate and learn about the long-term benefits and implications for these care models, and further explore ways of addressing care delivery needs, including home-based care, beyond what was ever previously imagined. In this way, we can renovate our currently challenged care delivery system to fully meet person-centered care on the ground. And truthfully, that could be a really delicious batch of lemonade from the incredibly sour lemon called COVID-19. So thank you so much. And I'll turn it over to Karin at the Commonwealth Fund.
Thank you, Mark, Ronny, and Gretchen. And thank you everyone for joining us today. I'm Karin Lewis, Program Officer for Delivery System Reform at the Commonwealth Fund, a foundation committed to improving healthcare practice and policy in the US, particularly for society's most vulnerable. As my colleagues have laid out so perfectly, we've come together as foundations to promote access to and quality of home-based care, particularly for people that need it most due to their complex medical needs, functional limitations, or social needs. The reason we're focused on home-based care in particular is because it's an evidence-based, comprehensive, and patient-preferred approach, and yet there is tremendous unmet need for it in the US. We've consistently heard that a major barrier to the scale and spread of home-based care is the untenable payment models, particularly the continued dominance of fee-for-service payment approaches. So over the last several months, we've supported the Duke Margolis team to tackle that very issue and identify policy opportunities to really align and scale value-based payment models for home-based care in Medicare and in Medicaid. We're excited to share and discuss those recommendations with you all today. Before I pass it back to Mark, I just really want to thank the entire Duke Margolis team for the excellent work on this project and for pulling together such a great group for our discussion today. Really looking forward to the conversation.
Great. Thank you very much, Karin and Gretchen and Ronny. Your support, your vision obviously matters a lot for continuing to make progress on this critical set of issues. And I do want to say one more thing before moving on to the next part of this session, and that is a number of you have already discovered that this is not just a meeting to attend, but one to actually participate in. If you have any questions or comments or desire for clarification, please use the Q&A tab on Zoom. As you can see, if you've got that open already, some good dialogue going there, and we'll try to get those questions answered and those comments or questions incorporated into the discussion going forward. So now I'd like to turn to Rob Saunders from Duke Margolis for an overview of our project work and findings to date to set up the discussions that are going to follow. Rob?
Thanks, Mark, and appreciate that that setup here, and we'll flag that we're excited about sharing this work. So what we're going to do over the next, say, 5-10 minutes is give a high-level overview of some work that we've been doing. And actually, Jonathan, if you go back to the last slide, do want to again thank our funders who've been really critical partners in making this project a reality. And we'll want to also flag, if we go to the next slide, what we're going to cover today. And for that, I'm going to turn to my colleague, Jonathan Gonzalez-Smith, who is going to help set us up for that and talk about where we are. So Jonathan, turning to you and maybe going back just a couple more slides. Jonathan, I think you might be on mute. Well, looks like we may be having some technical difficulties, but let's start off with really why we're talking about home-based care today. So, I think as Mark mentioned, and as our funders noted, there's a lot of reasons why we're interested in home-based care. One is that there is significant demand, which was only exacerbated during the public health emergency, for millions of people that are homebound and without some type of home-based care would lose that independence and lose the ability to stay at their home and in their community. We want to note, though, that home-based care is also really important because it addresses both medical and social needs. It's not just about the medical aspect here. Most home-based care incorporates activities that help with activities of daily living and helps longer-term care and support. Many of these services, though, are delivered by smaller providers, and the traditional way that we've been paying for our home-based care has been under a fee-for-service model, which has created some challenges. Jonathan, turning to you, I think you wanted to dive into some of those challenges.
Sure. And I think first, just reiterating that there are a substantial diversity in home-based care models. And giving sort of a high-level overview, there's a broad range and spectrum of services offered, Rob. Models vary both in the intensity and duration of services provided, as well as the degree to which they primarily address medical needs like hospital at home or social needs like home and community-based services. And while these models have been integral for serving populations with complex health needs, the substantial diversity can create a siloed approach to home-based care, which has led to concerns that patients aren't well supported during transitions between existing models. For instance, ensuring that when a patient is discharged from the hospital, that they would continue to have their needs met through home-based primary care services. So I think one of the things that came through in our findings is that there needs to be a model home that can encompass a range of services and supports continuity in care as patient acuity changes. But as you mentioned, Rob, there are a number of barriers that we identified to sustaining and scaling home-based care models. And I'm not going to go into each of these in detail, but I'll note that two of the more prominent themes that emerged over the course of our project are, first, many home-based care providers are not well supported in the predominant fee-for-service payment arrangement. And you heard Karin and Mark and others talk about this a little bit before, but just to sort of go into detail on this, traditional fee-for-service does not pay many of the team members needed for home-based care services, and often undercompensates for travel time. As an example of the latter, revenue in fee-for-service, since it's determined sort of by the volume of patients seen, providers have less of financial support to conduct home visits when they travel upwards of 2 hours a day to deliver care. Second, another significant barrier that many of you may be familiar with is the broader lack of infrastructure needed to support home-based care. There is a critical workforce shortage across both health and allied professionals in the home-based care space. And this is particularly acute in rural and remote areas and has been exacerbated by the pandemic. These constraints have hampered care delivery efforts, leading to significant delays in home and community-based service enrollment across states during the pandemic. There are also challenges with home-based care data collection and sharing efforts and measures. As an example, many current measures have been designed for the general population and may not be usable or relevant for individuals receiving home-based care. Value-based payment models, again, sort of reiterating something that's been said earlier, value-based payment models have increasingly been seen as a mechanism to overcome the limitations of fee-for-service and better align payments with practice by paying for improved quality of services, not simply the volume of services rendered. In doing so, value-based payment models can provide financial flexibility, allowing providers to more easily address the medical and social needs of patients. They also can allow for more clinically appropriate care and reward important services like care coordination, preventative care, and patient education. And there are a number of existing payment models that can be used to scale and expand home-based care. These will be explored in further detail in our upcoming panel and in the fireside chat. But in the meantime, Rob, I'll turn it back to you to discuss some of the policy opportunities.
Yeah, thanks, Jonathan. And so as we've done this project, we've heard a number of challenges, but we don't want to just end with challenges. We want to identify where there may be some opportunities to overcome them. So if we jump to the next slide, we tried to boil down all of those opportunities into four main buckets. And we'll stay relatively high level in this presentation because we want to spend most of our time on and the webinar and in the panels that follows next, as well as in the fireside chat. So I think the central point that we heard as we talked with stakeholders is really the importance of trying to create a pathway to integrate home-based care into a more whole person care experience, so that home-based care wasn't seen as something to the side or something that was just for very specific populations, but was really brought into the entirety of the healthcare experience. And that's going to require four main buckets of activities. One is to adapt some of our existing payment models to be able to deliver those types of services. And we identified a number of opportunities in our policy agenda briefs that will share after this webinar to really be able to modify, say, existing accountable care organization models like the Medicare Shared Savings Program or others to be able to support home-based care while making sure that we're providing coordination across the healthcare spectrum. Another point that we heard was the need to support small independent home-based care providers. And many of the home-based care providers out there are actually relatively small practices that have only a few hundred patients that they look after, only a few providers. And there's some unique challenges that happen in those types of arrangements that can make it challenging to move into value-based arrangements. We've seen some opportunities to address that type of issue in other types of value-based payment reforms. For instance, say independent office-based primary care providers have aggregator organizations that they've started to work with to help bring them together to provide common infrastructure while allowing for the ability to take on risk. And there may be some opportunities to leverage that experience, to leverage the idea of more advanced investment that can help smaller home-based care providers join. Another point that we heard go back one, Jonathan. Another point we heard very clearly was the need to address some specific technical considerations for home-based care. One, for instance, is some of the quality measures that are in use right now in general value-based payment arrangements don't necessarily reflect the care or incorporate the care that's being delivered at home. And therefore, we can not necessarily both assess the quality of what's happening, but also not take into consideration services that are being delivered that may be meeting the goals of those quality measures. And then finally, on the foundational side, this is where we're trying to get at some of the changes that have happened during the COVID-19 public health emergency, such as the expansion of telehealth, the introduction and expansion of hospital home programs, and being able to leverage those regulatory flexibilities, and especially think about, as we're hopefully ending the acute phase of the public health emergency, which of those can be continued in the after times and be able to be leveraged to support further home-based care work. And it's notable here that we really want to focus also on the workforce as well as the data infrastructure, as those are both very critical pieces to making home-based care possible. Then there's some specific challenges in those areas as well. If we jump to the next slide, one area where we are specifically thinking about is where there's those opportunities to adapt those existing payment models, and whether that's having different tracks or different specifications that apply to all. There may be ways to look at how to bring in that interdisciplinary team and help to transition when folks now need more services, their needs become more acute, to when they may be needing less care. So noting that is a really important piece, and we know that that's an opportunity for the future. So to close with the next slide, we've got a lot of momentum to expand home-based care, and we definitely have seen that momentum during the public health emergency based off of the need, but also some of the changes that we made during the public health emergency to care delivery that have expanded home-based care over the last several years. We know that value-based arrangements are really well suited to be able to support the expansion and integration of that home-based care, so that we are thinking about more whole person care and not just looking at silos and really thinking about how we can leverage that value-based payment arrangements, those financial flexibilities and other flexibilities to make sure that we're meeting the complex social and health needs of people who may be needing home-based care services. So let me stop there and we can pull down the slides and then let's transition into a conversation. And we've got a great panel today that we want to talk with who are going to give some reactions, some thoughts based off of these recommendations, but also building on their own experiences in home-based care. So let me introduce the four folks who are going to be on this next panel. And as I do so, I'd ask for them to take themselves onto camera. And I will probably do short introductions that won't even remotely do justice to their backgrounds, but want to at least be able to flag where they're coming from so that you know where perspectives are. So first off, we have Christine Ritchie, who directs research in palliative care and geriatric medicine at the Massachusetts General Hospital, as well as professor of medicine at Harvard. Dr. Ritchie is not only a geriatrician and palliative care physician herself, but she also is a national leader in really helping us understand how do we improve care for people with chronic serious illness and multimorbidities, and how do we take home-based, say, primary care to the next level? What are those effective care models out there? Second, I want to recognize Curtis Cunningham. Curtis is joining us from the Wisconsin Division of Medicaid Services. And Curtis is really responsible for acute and primary care services there, as well as long-term services and supports for the Wisconsin Medicaid program. He's been working in Medicaid policy for almost 20 years and is the board president of Advancing States. And he's going to help us really think about many of the nuances that happen as we think about home-based care for the Medicaid population. The third person I want to recognize today is Dr. Julian Harris. Julian is the chairman and CEO at Concerto Care. He's also the operating partner at Deerfield Management. And at Concerto Care, he works considerably on value-based care for at-home comprehensive care for seniors with unmet social and health needs. At the Deerfield side, he's built an entire portfolio on value-based care, population health, and diagnostics and digital health companies. Before he came to these roles, he spent time at the OMB, in the White House, as well as in Massachusetts Medicaid. And since this is a Duke Margolis event, we also appreciate that he is a Duke alum. And finally, but not least, Patrick Conway, who is the CEO of Care Solutions at Optum. And in that role, he's leading a portfolio of businesses that focus on acute and post-acute care, care in the home, care virtually, and a variety of other specialties. And Patrick's going to help us think about how these types of home-based care programs can be sustained, how they can be spread. So let me stop there at the introductions and kick things off. Really excited to have this discussion. And Christine, love to start with you. You know, as we've been talking about for the last half hour, there's really a great need for home-based care now. And you've seen this firsthand in your practice, but also in your research, and would really value your thoughts about helping us understand why is this important? Why are we talking about this today? And what are the challenges that providers are facing in trying to try to deliver this type of care?
Thanks, Rob. And as many people have already begun to think about and reflect, the pandemic has really laid bare the inadequacies of our current healthcare system, our over-reliance on bricks and mortar care, and our pivot to telehealth, which while is adequate for some, is not adequate for all, especially those with hearing and visual limitations, cognitive impairment, lower digital literacy, and those without broadband access. And there are a number of people who are high-need who come from high-need situations who are not able to access traditional ambulatory care. They, based on some of the work we've done in the past, represent about 7.5 million Medicare beneficiaries. And in 2020, when we re-looked at these numbers, we saw they actually had dramatically increased during the pandemic. The sad news is that right now, only about 12% of that homebound population is receiving home-based medical care. So for that population, virtual care often is not sufficient, especially when they need hands-on assessment or when there are urgent care needs. So there truly is, as has been already described, a need for an integrated system of home-based care that includes both longitudinal and episodic or acute care. And the challenges, as has also been described, is that the fee-for-service reimbursement model does not work for this kind of care. It incentivizes high volume, and the travel time and the other complexities of care in the home are not accounted for. So we hope that we'll be creative about some of the ways we could use true value-based person-centered care so that people are getting the right care at the right time in their home, which is where they'd like to receive it.
Thanks, Christine. And I think you did a really good summary of the big challenges. One of the questions we got from the audience, and would value just answering this while we're on this point, is so what are the challenges with reimbursing for an interdisciplinary team under the current fee-for-service arrangement? Clearly, some members of that team can be reimbursed, but this is a challenge, and would welcome quick thoughts from you. Why is that such a challenge?
It's a significant challenge if you're really trying to address the comprehensive holistic approach towards care that includes attention to a biopsychosocial model, because the billing providers who are that member of the team generally represent people who are physicians, nurse practitioners, or physician assistants. It's possible that you could have a psychologist or a social worker who can bill modestly for therapy type services, but by and large, most of the care that's provided through an interprofessional care team does not constitute billable services in our current framework.
Thanks, Christine. And Patrick, I want to go to you next. Clearly, in your current role, you are thinking about different ways of paying and supporting different types of home-based care. Would be interested in your thoughts broadly about, well, so what are the new types of ways? We say value-based payment, but that encompasses a lot. Are there specific ways that we can leverage value-based payment? Are there specific practical next steps that can help with new ways of paying for home-based care?
Yeah, I think to truly unlock the value, you need either full population-based payment, meaning, a percent of premium from the payer to the provider, which we do today, or a real shared savings, meaning, 50% up and downside as an example. So we have hundreds of thousands, about 500,000 right now, people, dual eligibles and Medicare Advantage that Optum and Care Solutions, businesses that I lead, are taking full risk on. And I think that's when you can really invest in physical, mental, and social care. And we do that across payers, obviously for United Healthcare, but we work with Optum works with about 9 out of 10 payers in the country. And even in our business, we work with a large number of payers in that kind of arrangement. You can provide episodic care, and we do that too. We do over 2 million visits for various things, nurses in the home. We do virtual care into the home. The fee-for-service model, though, as was described, it's not transformative. It's, a single visit paid at a certain rate that closes some care gaps, address some needs, but is not really holistic physical, mental, and social care. I think you need more of a population-based payment model to do that.
Thanks, Patrick. And one of the questions where I'm sort of live bringing in the audience questions, one of the questions that we're hearing is, can you talk a little bit more about the challenges for the home-based care for the dual eligible population? I suspect that Curtis and Julian may have thoughts on this as well, but since you mentioned duals and the audience there and you have the seat, I want to give you the first chance.
I'll start, but I'm happy to learn from others. Look, I just started my 3rd year at Optum. So very early on, we started a program that we built from scratch called Optum at Home in one state that was full risk care from duals. It is now heading towards 15 states. And what's exciting about it is it works. So total cost of care goes down about 20% on average. NPS is high 80s to 90s, and 100% of the members are in 4-star or greater plans, many of them in 4.5 or 5-star. To give you an example of a typical member, a complex member, dual eligible, we may see 9 times a year in the home. Real anecdote also helps in addition to data in life. Real member that we featured, hospitalized 12 times the year before, went down to 0 because you surround them with physical, mental and behavioral and social, so to social determinants of health, et cetera, holistic care. So super excited about the work in the dual eligible space.
Thanks, Patrick. Julian, I want to turn to you. In your current role, you have been thinking deeply about a variety of value-based payment approaches for home-based care. Would be interested in what you're seeing from your vantage point on how you've been able to operate in those value-based payment arrangements. And then are there some ways that we may need to support those types of transitions in the future?
Sure, and thanks so much for having me. It's exciting to have a chance to participate in an event sponsored by my alma mater. Duke was actually one of the last places I went in March of 2020 before the world changed. So things coming full circle as we're beginning to open back up. I think a lot of the points on this have been touched upon, but as mentioned, I run a company called Concerto Care that brings an approach to leveraging interdisciplinary teams to support patients in the home who have complex medical, behavioral, and unmet social needs. And we do that both in partnerships with Medicare Advantage and duals plans, but also working with CMS through their value-based care programs. But there are challenges if you think about a model like ours, where we do actually have kind of the more robust form of an interdisciplinary team, where we have physicians and nurse practitioners and medical assistants and RNs, but we also have community health workers and social workers and geriatricians and palliative care physicians and geriatric psychiatrists, et cetera. It's a very, very robust model, and it's just a model that can't function in an optimal way in fee-for-service. You really need a value-based construct that enables the kind of investment, frankly, that we make in taking care of the patients who have some of the greatest need, who have some of the biggest opportunities to improve quality, and who account for an outsized percentage of cost per member. And so, a lot of what we spend time thinking about is if you take a step back and abstract away from the payment system, just begin with how should care be delivered for this population. And our thesis and our approach is to actually really build up from that and deploy and deliver an integrated model of care. A number of things which we deliver ourselves, and then in certain areas we're going to partner. So we don't have home health agencies that are part of what we do, but we work with home health agencies. We don't deliver personal care ourselves, but we not only know the agencies, but we know our patients' personal care attendants very well. And we effectively pull them into the care team and leverage their insights as we think about how we optimize the patient's care. But those home health providers and those personal care providers are not necessarily a part of kind of the economic structure, certainly not a part of our organization, but we're looking for opportunities still to coordinate with those other components of the ecosystem. So, our team really orients around how should the care be delivered, what should the model be, and then we try and figure out with the framework that we have today, what are the ways to try and get reimbursed for it that support the kind of investment we make, but also the kind of outcomes that we can drive from a cost and quality perspective. So there are ways to think about that in Medicare Advantage. We have some very innovative and forward-leaning Medicare Advantage plan partners who've worked with us to think about an economic model there, and same on the dual side. And then there are some models from a CMS perspective and an innovation center perspective that create at least avenues for companies that are thinking about value-based models, whether they be total cost of care or in certain cases, ones that are focused on specific chronic conditions.
Okay. Thanks, Julian. And Curtis, would love to hear your feedback on this. Medicaid is such a key partner in a lot of home-based care. There's been a great transition toward home-based and home and community-based services over the last several decades. And home-based care, as we're talking about today, encompasses home and community-based services, but also thinks about the intersection with home-based medical care as well. And wanted to talk to you, especially given your national leadership here, on where are the opportunities in terms of states being able to provide many of these home-based care services, and where are there some opportunities, especially in Medicaid, to expand access to these types of home-based care?
Yeah, I mean, I guess in Wisconsin, I'll just say we're fortunate. We have expanded our home and community-based services program statewide, and we're at entitlement for people with physical disabilities, frail elders, and individuals with developmental disabilities. So, and we cover pretty much anything you can cover in the home and community-based space. So the first point I'd make is on value-based purchasing is cover home and community-based services and expand that statewide. You know, you rebalance your system, there's significant savings from moving from a institutional-based model to home and community-based services. And we've moved to about 80% of our spend is now for home and community-based services for individuals that are at an institutional level of care. So that has created a significant savings, as well as you know, better outcomes for our members. We also then, once you get to just a holistic environmental scan, we run a variety of models that are value-based in various ways. We do have a fully integrated FIDA-SNP, which is a partnership program, which includes all acute and primary and home and community-based services. And that's probably the gold standard in value-based purchasing, allowing the MCO to leverage savings across both the medical and the HCBS side. We have a family care program where we capitate the long-term care services and the HCBS services, so behavioral health, nursing services, and all the home-based supports. That is our flagship model. And again, that allows for leveraging across various systems. And we have an IDT team that has a nurse, social worker, and it's really an outcomes-based model, because I think when you, in many ways, medical is focused on treating the person, where the social model is really about removing barriers to the person. And I think that's how you marry those two philosophies is a really important thing to talk about, where you get value, because putting those two things together, value may be different from person to person. So those are a couple things. We have a self-directed program where people can hire neighbors and others to leverage, you know, workforce, and also usually at a much cheaper cost rate. So that's another thing that contributes to that. And I'll just add 80% of our long-term care population is dual eligibles. And we still have a lot of work to do to talk about how to marry many of the government CMS policies, whether it's the Medicare, Medicaid, acute and primary, along with the HCBS, to create a comprehensive model. So look forward to the conversations.
Thanks, Curtis. And I want to pick up actually on a point that you and Julian both raised, and it's also something that we're getting through the questions from the audience, and that is one of the advantages of home-based care is that we're having people be able to spend more time at home. That does, however, mean that there has to be some level of caregiver support and social supports in the home. And you know, that could present some equity challenges over time if certain disadvantaged populations, say, do not have the same type of caregiver support, where, say, they've got family who can take time off work, or that they have the ability to hire personal care workers who can help support them. And I did want to ask that question to the group. I think, you know, Curtis and Julian, you both highlighted where some of the value-based payment models can support many of those types of personal care and caregiver supports, whether that's respite care or other types of in-home support services. But this seems like a really important issue, especially given the nationwide focus on improving health equity, especially through value-based care. So throwing this open to the panel to see if someone wants to think a little bit here. And Julian, I see you went off mute first. Oh, you're on mute on the other line though.
Sorry, my computer microphone wasn't working as well, so I'm dialed in by phone. I think this is actually one of the greatest kind of health equity challenges that we face, to be quite honest. When I refer to our patients having access to personal care attendants, these are patients who either on the Medicare fee-for-service side or personal care attendants in home health. These are patients who generally through access through the Medicaid program will have access to personal care. But we have a long-term care crisis in this country, and I know that is a whole topic of conversation and could be its own panel, and something I've had a lot of passion around and spent time on throughout my career. But I'll just say at the highest level that for people who don't have long-term care insurance, which is the lion's share of the population across income groups, and for people who don't meet Medicaid eligibility criteria for personal care and live in states that have more rather than less kind of generous personal care benefits, it really is a challenge. And it's not just a health equity challenge, it's a gender challenge, because in many cases, the people who are trying to find ways to support those loved ones, whether it be a parent or grandparent or a spouse or a child, in many cases, those are women who are trying to do that and juggle a number of other balls. So, this is, I think, something we need to continue as a country to have conversations around. We don't have a way, certainly in the context of the work that we do, for a patient who doesn't have access to personal care, generally through Medicaid or again through long-term care insurance. We don't have a way to provide that or to reimburse for that, because it's just not the way that the economic model is structured across Medicare. And again, even in the context of duals or patients who are in the Medicaid program, it really depends in part on the structure of that benefit in a given state, whether you're eligible for it. So it's an issue. I don't have a silver bullet solution, but I want to continue to be a part of the conversation to raise a flag, because we talk a lot about health equity, but this is one of the areas that I think really is one of the greatest drivers of healthcare inequities across a number of kind of dimensions.
Thanks, Julian. And since this is so important, wanted to see if other panelists wanted to jump in on this question as well. There's things that other considerations that we may want to think about, especially in leveraging, some of the flexibilities we have, or in thinking about where there may be some opportunities to use home-based care to address this. And Christine, I see you went off mute.
Yeah, I just want to thank you, Julian, for commenting on the inequities that essentially this issue sort of engender, and it's a very important issue that we're going to have to address. It's also a sensitivity that we need to constantly think about when we're thinking about moving care to the home. So as much as that's person-centered care, and that's the care I think most of us would want, it is predicated on there being care partners that are part of that support, especially for people who have cognitive impairment or other mobility challenges that require support of others. So that sensitivity and really addressing that, obviously at some point from a long-term care sort of larger policy perspective, is going to be quite important.
Thanks, Christine. Another question that we've been getting through the audience and would be interested in this group's thought is, and it builds on some of the conversations we've already had about changes that have happened during COVID. There have been a lot of changes during COVID in terms of greater payment for telehealth, greater use of telehealth, also other types of support for in-home services, such as, say, the acute hospital home program, recognizing the need for both capacity at our office-based or facility-based healthcare organizations, but also recognizing the need to have people at home, especially those who are more medically vulnerable, because there was the real risk of seeing COVID transmission occur in facilities. And as we are hopefully approaching near the end of the acute phase of the public health emergency, did want to throw this out to the panel as we think about, well, which of those types of flexibilities do we want to be able to keep, and how do we leverage some of the new value-based payment models in order to do so, whether that is using telehealth or other types of remote monitoring or technologies to, again, augment the support that's happening in the home, or if it's thinking about using some of the new care models that maybe were only research projects before the pandemic, and then now are nationwide with hundreds and hundreds of sites using them. Would be interested in the panel's thoughts if there's ways to do that. And Patrick, I see you went off mute first.
Yeah. So even when I was at CMS and CMI, I wanted to loosen up telehealth, and we did waivers, and I wish we'd done more. Let me be clear, I'd make it almost all permanent in terms of the telehealth. Everything that's statutory allowable, I would make permanent. I think the rhetoric around like fraud and program integrity issues, I think you can address different ways. I don't fundamentally think the benefit far outweighs the risk. And mental health, I also have our mental health benefits business, so I see the data. Over half of the care is still telehealth, and the patients, the members, the people are telling us they like it. We should listen to them. So that's sort of the telehealth part. Home-based care waivers, including hospital at home, I would try to make permanent. There's actually, that you'd have to figure out then, do you do that through CMI or other mechanisms? If you can do a hospitalization in a home setting for X% less cost and the quality and experience is better, we should allow that. This is where sometimes government has to get out of its own way. And so, I'd make a lot of that permanent. I'll throw in direct contracting, I know is being debated right now. I would modify it. I wouldn't get rid of it, just to say it out loud. I'll say it now. I'll take the opportunity because I think you can modify it in a way that still adds value and creates opportunities for providers. So, I think we're going to hear from Chris later. Great team there, and I fully support them, and I hope they have the ability to make a lot of these things permanent.
Thanks, Patrick. And Curtis, I was actually hoping you would go off mute because I would love to hear, on the Medicaid side, we talked a little bit about Medicare. The Medicaid side, Medicaid programs have been really busy over the last couple of years.
Right. First off, for the telehealth stuff, we did take full flexibility of all the advantage of all the flexibilities that were provided. And now we're talking about what does it look like when we get out of the public health emergency, and what's our new policies. One of the things we're highlighting is the reimbursement of originating sites. Our original telehealth policy was limited to only physician offices and outpatient hospital clinics where the member would be. By expanding originating sites to almost all Medicaid provider types, we're looking at you'll be able to get telehealth in a pharmacy and other FQHCs and things like that. And our eventual goal is to expand that to HCBS settings so that you could do telehealth for someone that's in an assisted living, and you could be reimbursed. The originating site would be reimbursed for the work that's done there. And then eventually, if we get there, looking at homeless shelters, other places where our populations may be, because by getting the services, I do feel like that's the first step. Getting access to the needed services is the most important concept there. And then I also think in the future, we're going to see a lot more remote supports and remote patient monitoring, and all those telehealth originating sites having the functionality necessary to do that will be really critical. There's other flexibilities that we have been using. I like the hospital at home model. It wasn't taken up broadly for a variety of reasons. But I really think we need to get to more of a comprehensive model that's not only hospital at home, but also includes the home health, the home and community-based service supports and everything. So that's where I hope at some point we can come together, because I feel like that's really where the value is to put all that together in one program.
Yeah, and Chris, I appreciate you saying that, because I think that is one of the lessons I've taken away from the work that Duke's been doing over the last several months is really, it's not about starting 20 different types of programs, but how do you bring all these pieces together so that we don't create more silos but are integrating, because people's needs change, their acuity changes, and you want the level of services and supports to be able to work with them and to meet them where they are. Shifting gears a little bit here, Christine, we talked before about some of the small providers that are providing a lot of these home-based services, and what the infrastructure needs to be to support that. in your research and your engagement with providers, can you talk about what supports those providers may need in order to continue providing the home-based care they are doing, and how do we help them make those transitions to value-based care?
Mm-hmm. There are a number of things I think that are necessary sort of from a big picture perspective to support those programs. Certainly having coalitions of those programs so that they have economies of scale or connections to health systems and payers will help them not be sort of solo out there trying to do their own thing. The other two things that are going to be very important for them, and this is something we've seen a lot with our National Home-Based Learning Network, is that people need access to data, and they need access to data in real time so that they can actually provide the right kind of care at the right time, and so that they can think about and look at their quality. Right now, it's difficult for them to provide those services in any kind of meaningful way without data, especially the kind of integrated services that Curtis was talking about. If we're really talking about integrated services between home and community-based services, hospital at home, home-based primary care, home-based palliative care, ideally those services are integrated. There's data sharing, and then the right person is caring for that person at the right time. That is not currently in existence for most of these practices. And I think the only way they'll get there is through the development of some kind of coalition or working with larger systems of care so that they can actually have that kind of data infrastructure.
And Christina, I'm glad that you brought up data as one of the questions in the chat you preemptively answered, which is, some folks were asking, well, don't we need a lot of data in order to be successful in value-based payment, even outside of home-based care models? And I think just to repeat what your answer is in fact, yes, it's even more than you may need in the office-based settings, given the number of types of services that are being delivered and the fact that you're having to do this all virtually and in a person's home. Just to maybe dig a little deeper on this point, are there specific types of data infrastructure that could be supported here? I mean, is this about more, health information exchanges, more access to ADT feeds to know, access to hospital or the like, just maybe dig in a little bit, and then that may help as we're thinking about the payment models that we're looking at in the future.
Mm-hmm. So I would say, I'd love to hear Patrick's perspective on this as well. Amazon Fresh can get us groceries when we want it. So we should be able to give people the care they need in the home when they need it in a proactive as opposed to reactive way. It's really about having the data in the right place, the processes in place, the supply chain, the logistics, all of those working synergistically together so that if a patient has a non-functioning Foley catheter, the home health nurse or whoever is going to see that person home has the has the Foley catheter in real time to provide it. It's these kind of important sort of logistics, supply chain issues, along with all of that being integrated into data that's going to be necessary, I think, for us to do it well.
And Patrick, you were teed up here. Did you want to jump on this data point as well?
Yeah, I totally agree. I mean, I'll be brief. We talk about is how do you track Mrs. Jones over time in a seamless way? So, how can that person and the caregiver that cares for them get a nurse visit, a prescription, visits their clinic, and actually the information flows from the clinic to home and community, which we're working on right now, so that everybody has the same information on the care team and the caregiver and the patient have that information. A mental health visit, a virtual visit. We have not, it is not as seamless as we would want it to be clear. These are journeys, but I was just with our technology team, actually, interestingly, right before this, talking about this, that eventually, if your mother was a United member or a member of a different health plan that we serve, that we can get her any physical, mental, social needs she wants, that day, if possible, or immediately as possible. And that information flows across the care team and across her and her caregivers.
And all of this requires infrastructure, which is, I think, one of the key points here. Curtis, maybe turning back to you, over the last year, there have been some investments coming through and state Medicaid programs, especially in the home-based care, home and community-based services spot, say like ARPA funding or other supports. Are there additional actions, whether through those vehicles or through 1115 waivers or others, to be able to help providers get this type of necessary infrastructure and upfront supports? That seems like that's really critical if we're going to try to make this move to more value-based payment arrangements.
Yeah, I mean, the EHR funding leaving out HCBS was in behavioral health. It was a significant, creates a significant problem, and I think we're all trying to catch up with that. So for our ARPA funding, I guess a couple things specific. We are looking at doing a diversion program. A lot of the individuals that are now coming in, now that we're at an entitlement for HCBS, a lot of the individuals coming in are spending down into Medicaid from, and usually then in an assisted living or some other non-home setting. And a lot of it we're seeing through anecdotal evidence is a lot, and we saw this significantly with the backup of people into hospitals, trying to get into nursing homes, and not being able to get back home, was that just for a few supports, we could likely get them back into their home, whether it's a quick home modification, a wheelchair ramp, some other HCBS services that are not currently covered under Medicaid. So one of the things we're funding is a pilot to look, it's called Independent Living Pilot, that we will be covering caregiver training and certain supports that can assist a person coming out of a hospital or nursing home or needing to stay in their home with a small amount of funding. There's some other states that have had significant success in this. So that's one of the things. We also have a significant pool that's reserved for grants for home and community-based services and to expand home and community-based services. And that's where I think we're hopeful that providers will take advantage of funding some of that infrastructure need. And then the final thing, we are building a critical incident system that will be able to look across our adult protective services, our adult long-term care, and our counties, so that at least for the most vulnerable populations and situations, we are having a communication tool that alerts people across the system so that people are not put in dangerous situations anymore. So it's just a couple of things.
It's more than a couple things, it sounds like. You guys have been busy. So one question I do want to ask, and this probably goes to Patrick. So we talked about Medicaid. So the Medicare Advantage side, there are some existing flexibilities out there now, whether that's through the dual special needs plans, the DSNPs, or whether that's through the new supplemental benefits from the Chronic Care Act. Many of which have components that seem like they could be pulled into this, like in-home support services or respite care or caregiver supports. Curious from your perspective, Patrick, if there are some flexibilities that are under leveraged here, or maybe that could be expanded to be helpful for this type of conversation.
Yeah, I think the biggest thing I'd call it here, those flexibilities, the Medicare Advantage and DSNP flexibilities you name, both supplemental benefits and other flexibilities, it's how we do this work, just to say it directly. Like the vast majority of our home and community full risk work is in Medicare Advantage and DSNP. And so I think the question you've heard from Curtis on some of the state things and how to state support that, I think for the federal government as well, and I know we're going to hear from folks later, how's the federal government support that in traditional Medicare? I will tell you, we also serve traditional Medicare. It's significantly harder because it's a fee-for-service stream that just doesn't support that sort of, the supplemental benefits, the enhanced care, visits, like we're talking about, where you may surround somebody with 9, 10, 11 visits a year in the home, where you do virtual care and you no longer care, the flexibilities are irrelevant because you're getting a % of premium payment. So you figure out how to make it work with that capital flow, if you will. And so I think these flexibilities are essential. And then I would encourage both federal government and state government in both traditional Medicare and Medicaid and commercial payers, by the way, to figure out how they make similar flexibilities available if they truly want to enable comprehensive home-based care.
And Julian, in your opening response you noted some of the Medicare Advantage work, that partnerships that you have, but want to turn to you as well as you're approaching this on that side of the value-based payment arrangement. And where are you seeing activity, where there's some flexibilities, whether in the MA side, whether that's in the traditional Medicare or in the Medicaid or commercial side?
Well, I'd say on the Medicare Advantage side, we work with patients, if we're working with a plan through their Medicare Advantage program, but the patient happens to be a dual, for example, and they've got a personal care attendant, but that's through a different plan, we're there for the patient, right? And that sort of, I always go back to, we abstract away the reimbursement system and try and kind of think about how we deliver an integrated model of care and then reapply the reimbursement system, but really start from kind of the patient and how care is delivered. So, we will work with that patient's other providers who may be reimbursed by either fee-for-service Medicaid or by a different Medicaid plan, like a personal care attendant or others, and just sort of on our own try and make that coordination and collaboration happen real time. We just do the work, whether or not we're compensated for it today in the current structure. I do think one of the things that is exciting about some of the more advanced value-based care models that both health plans have, but also that that CMS has developed, that really kind of build on that ACO foundation. And Patrick alluded to, but I think the global professional direct contracting model, which really is sort of an ACO model, really kind of builds on the foundation of the Medicare Shared Savings Program and the foundation of Pioneer and NextGen. I think that model really does actually provide a path for providers who are looking to provide more intensive care in a way that you just can't do in fee-for-service. If someone knows a fee-for-service practice, out there that is, providing kind of, and I won't rattle through, what I shared earlier, but just providing the kind of comprehensive model that we deploy in a fee-for-service context, it's really, really challenging to do that and make that work economically. And so in a risk context where you're rewarded for improving quality of care, for coordinating the care, for helping to make sure that patients' care is optimized, but also it does result in savings, because foundationally, if you can keep people from needing to go to the ED or to urgent care, or if you can avoid an admission because you're actively managing their chronic conditions and acute exacerbations of those conditions, then there's an opportunity in a value-based care context to participate in that economically. And so, we're hoping to see more rather than less innovation in terms of thinking about new kind of payment context, not just on the fee-for-service side and from the Innovation Center, but frankly from health plans. Health plans are not all in the same place in terms of their innovation journeys from a value-based care perspective. And we're hoping to see, much more sort of creativity over time from plans looking to partner with organizations like ours around the most complex populations.
I appreciate that, Julian. And I think what I'm hearing from everyone's feedback on these questions is that there's some opportunities out there that we haven't been able to leverage as far as we want to. But if we are able to use more of these types of value-based payment arrangements, we're really able to help everyone, whether that's folks who are in the Medicaid program, folks in Medicare Advantage, folks in Medicare, folks in commercial. And I think one thing that we've been hearing on the questions from the audience is really thinking about, the almost called the forgotten middle, the group of beneficiaries who may be only on traditional Medicare, they don't yet qualify for Medicaid, but they do need a lot of services and supports, oftentimes in the home, and that they can be in a particularly vulnerable situation here because they don't necessarily have the benefits and support that Medicaid provides, and yet they do have the need. And the hope would be that some of these value-based payment arrangements could help with that type of support, that making sure that we're meeting all populations regardless of who their individual coverage option is. Christina, maybe I wanted to turn to you a little bit on this question, since I know you've done a lot of thinking about, how to make sure, and this ties back to our earlier conversation about making sure we're providing services to those who are most vulnerable. How, from the work that you're doing with your home-based primary care groups, how are those home-based primary care groups working with different types of payers, recognizing the different models that each one have developed, but also recognizing the needs don't necessarily track to coverage? And curious if you have reflections or reactions off of that.
Currently, there's a wide spectrum of activity out there. So there are practices who are very much in the value-based care space, who are working with a number of different groups to, be able to provide sort of more holistic care. And then there are others who are trying to slog along in the sort of more traditional fee-for-service model. And I think there's an increasing recognition to do this well. It's very difficult to do this well in a traditional fee-for-service model, unless you're part of a ACO or some sort of larger system that accrues some kind of benefit for it. And we're seeing, I think some of these practices are, again, quite savvy, and others are sort of coming to a realization that their aspirations are going to have to be fulfilled in a much more thoughtful and sustainable way. I think the one thing we haven't quite seen yet, but has been sort of alluded to before, is, which I do hope we'll see increasingly, are the sort of blending and integration of these different kinds of home-based care services, so that, acute care at home, episodic, care like rehab at home, and longitudinal home-based primary palliative care are all part of sort of a true continuum of care model. And that is not something that we're seeing quite enough. We're not seeing that go on, I think, to the degree I think we'd like to see it go on in the future.
Absolutely. And I think that is one common theme across not only this panel today, but it also in the work that Duke's been doing is how to do that well. Because you're right, we have a lot of the building blocks here now. We've got really great home-based primary care providers. We've got some new hospital at home, but this will actually be transformative if we're able to actually bring it across that for everyone. So I know we're approaching the end of our time, but do want to make sure we do at least one last time to talk through each of the panelists, just in terms of, in a few minutes, where are you thinking about, where the future might be, and what would be the 1 to 2 things that would really make an absolute difference, as we're talking about changing to value-based payment for home-based care and really advancing this home-based care delivery. And maybe I'll start with you, Julian, and then work from there. So Julian, do you have thoughts on, what would be on your wish list if you had a magic wand?
I think fundamentally, and I'll go back. I have my themes and I stick with them. So, I think fundamentally, I wish, folks who, have jobs like the ones that Patrick and I used to have, and folks, folks who are at health plans would sort of do what I was describing, which is imagine what you think the delivery of care should look like, and then think about how we should pay for that. Because that optimally, if we're sort of thinking about how we optimize what happens for patients or for the beneficiaries through the kind of lens of a Medicare program or a Medicaid program, if you're trying to optimize for managing costs and you're trying to optimize for improving quality, I fundamentally believe that kind of patient up view would get us to a better answer than what we do today, where we basically just start with the legacy that it's built up since the Medicare program and the Medicaid program were started that is incredibly arcane and complex. And then we try and sort of move the pieces around and figure out how we can actually, structure an economic model that ties together and makes sense. So, if you're in a position where you have something of a white sheet of paper, to think about what does it look like to actually structure payment models that enable as much coordination as possible across primary care, behavioral health, specialty care, acute care, long-term services and supports, and unmet social needs. And we're seeing some of that kind of forward-leaning creativity, as I alluded to, from some of the plans in the country. And we've seen CMS try to take that on through some of the innovation center models, but there's clearly quite a bit to do. And so I'd encourage that kind of bottoms up or patient up thinking, as opposed to sort of top down, how do we fix the brokenness, to like bottoms up, how do we actually make a payment structure work for patients and for beneficiaries.
Absolutely. And you're right. We do have a very filled in sheet of paper right now, and it is helpful to start with, where do we actually want care delivery to go? And then we've got a lot of levers that we can use to help get us there. Curtis, the Medicaid program has a lot of levers, and also I would say is also a very filled in sheet of paper in some ways, but you've been able to be creative. If you had a magic wand, what would be the one or two things that you would use that magic wand on to help with home-based care and improving care for this population?
Well, I guess, we've organized in Wisconsin now to be member-centered, and I putting all the Medicaid benefit policy under my area to look at really person-centered care. And we've done an analysis over the past 2 years. And what we see is, I don't know if I'm visually going to be able to explain this, but basically the state's at the top, and then we have a whole bunch of silos. We have pharmacy carved out. We have transportation carved out. We have your home and community-based services. We have your acute and primary, your behavioral health. And then if you're in Medicare, you got this. So we're leaving, and there's good reasons sometimes for whether it's financial or programmatic specialty to have these various programs to support people. But what that does is leaves our members to navigate multiple systems to get their care they need, and ultimately probably a high success of failure and actually getting what they need. So, I'm trying to propose that we need to flip that triangle, put all the things together and have it flow one central place to the member so that they can get the services they need. And that's a very difficult conversation. I think it's where we need to go. I think it will create value, because if the ultimate value is when people are living independently and healthy and are healthy in the community. And so that's where we need to go. One other point I forgot to mention is the use of virtual supports through home and community-based services is a great way to do both medical monitoring and other things. And we have systems where we have remote monitoring that send people to the house within 5 minutes if there's an alert. So that's another use of that technology. But I really just think when we talk about value-based care, we really need to talk honestly about eliminating those silos.
And I think, Curtis, you're also building on Julian's point that let's not start with everything as a given, especially, there's a history and a reason why many of these carve-outs exist. But over time, there's some substantial challenges and how that may affect the specific care model that we'd like to see. Christine, you've been doing some amazing work over the last several decades thinking about home-based primary care and actually living it. If you had a magic wand from that experience, what would be the 1 to 2 things you would change?
Well, I would create a reimbursement model where the following thing could happen, which is where one of my patients who has dementia, heart failure, mobility issues because of chronic arthritis, diabetes, stage 3 chronic kidney disease, is seen at home by his home-based primary care provider. He gets a full interprofessional assessment of his biological, social, and psychological needs. And when he develops acute shortness of breath, ED at home evaluates him rapidly. They recognize that he has heart failure decompensation and admit him to hospital at home. He gets aggressive heart failure management at home. He's called regularly by his team, and his care partner is supported. And after his home hospitalization, he gets discharged to quote unquote rehab at home. He also engages with home-based palliative care to address family needs and desires around end of life wishes. I think that would be beautiful. And as somebody who took care of both of my parents the last years of their life in my home, I would have given my left arm to have something like this. So I think it's, that's the kind of, getting back to what Julian said, is let's start from scratch. Let's start from scratch and think about how we can actually provide the kind of care people really want that really helps them support their dignity and the respect that they deserve.
Thanks, Christine. And I think that's a really important vision that we should all be shooting for. Patrick, you have the last word in this panel. So the magic wand is turned to you.
Building what Christine said, that is the care we'd want for our parents, everyone we know. Like if you think about I think you also in the beginning on the addressable market, my guess is of the need, we're scratching the surface. We're giving that level of care to, 2% of the 100% that need it. So my goal would be we get to 100%. And then the question is, how do we get to 100%? And I think the big categories are one, every public and private payer in America move to a true sort of population-based payment model. I know CMI announced by 2030, I'd advance that. I know Chris is about to come up to like 2026, a little faster. Blue Cross North Carolina, we were moving fast, and it's what I do in my current job. So that's the payment piece which we talked about. I think there's a regulatory piece that we talked about. And then lastly, and represented by some of my colleagues here on the call, those of us working with folks providing care, that we enable that system. I did, to end on a patient story, there are complex kids that I care for that should be cared for in the home. And I went on a ride along with one of our providers in South Boston the other day, and to walk into a 93-year-old woman's home and see her hug that physician and talk about how it changed her life, like that's why you do the work. And so, how do we enable that for everybody?
And I think that's a really good note to end on. So I want to thank all of our panelists here and for your time and expertise and for the good work that you do. And turn to Mark, and I know we're really excited to have Chris Ritter from the Innovation Center join us. So thanks all.
Great. Thank you, Rob. And my thanks too to Christine, Patrick, Curtis, and Julian for an excellent discussion, which we're going to try to build on right now. And as Rob mentioned, it's my special privilege to be able to introduce Chris Ritter, who is the acting deputy director at the Center for Medicare and Medicaid Innovation, and also the director of the Patient Care Models Group, which Chris has been leading since 2016, which, and at least this is how I understand the group, Chris, develops and implements episode-based payment initiatives, more longitudinal payment reforms for a wide set of models of care where specialized interventions are required. This includes some of the most important models of home-based care to date, other specialized care needs. We're just hearing about hospital at home and other kinds of services. So these are some of the most important models for the beneficiaries that we're talking about today. Chris, you're pretty much covering all of healthcare between your two hats now that really matters for people who have special or more complex needs, and in turn, who really need the healthcare system to come together as effectively as possible to support them in achieving their goals, ones that we've just heard eloquently about from the last panel. And you've got a lot of experience before these current critical jobs. Before your time at CMI, you held some leadership positions in the Center for Medicare, handling the traditional Medicare payment policy for hospitals, physicians, and also some experience working on improving quality and accountability in the Medicare Advantage program. So one of the true essential persons for CMS payment reform. Chris, thanks for being with us.
Wow. Well, thank you for having me. Thank you very much. This is a wonderful conversation to have. And I had made some talking points ahead of time, but listening to the last panel, I think inverting the triangle and removing the cementing that fee-for-service does to specific services. I mean, it's all very, very critical to sort of thinking through how to undo what is a very modernistic approach to payment that sort of assumes a particular structure. And, going back to the home in an interesting way helps us look at that. So we're super excited about it and to talk today.
Well, great. Well, so picking right up on that, there have been a number of references already today to the CMS. Really, it's a whole agency level strategic refresh with this vision around creating a healthcare system that achieves equitable outcomes through high quality, affordable, person-centered care. And that's for everybody, just about in Medicare, just about everybody in Medicaid. And it does seem like it's going to be hard to get there without the kind of payment reforms we've talked about today, particularly for those those patients with complex needs who want to be at home. So these home-based care reforms seem pretty central to the goal. Maybe you could talk a little bit more about the strategic refresh and how it connects to some of these topics today.
Absolutely. Of course, the strategic refresh was released in the fall. And there have since, as you noted, been different strategies that have come forward for across the entire center. I think we were first out of the gate, so a bit of the guinea pig, but several of the key components of the strategy really address this entire conversation, which is really trying to help us rethink the healthcare system, especially on the end of the pandemic, as we think about like, what is it we really need to achieve in healthcare? Not just the savings, but creating a system that works for everybody, that is flexible, to be adaptive, as we've just been through this exercise, to be supportive, and that moves us forward in a way that we've not been before. And so the key components of that refresh, which is all available on the Innovation Center website and folks are probably familiar with, include, of course, affordability, accountability, and care innovation, all equity, really key pieces that goals everybody has had. I think the purpose here is to really try to bring them together as we have a very specific goal, as Dr. Conway alluded to, in terms of getting to in 2030. And so home-based care, which is the focus of today's conversation, really falls for us under that innovation in care pillar. It's not something, there was absolutely a movement to home and community-based services we have seen before the pandemic came in, but clearly the last several years have really raised for us the importance of rethinking those care settings in a way that we just wouldn't have had the impetus to do before, I think, or to do as quickly as we might have. And so we've really got that threaded throughout the strategy, and it is a definite focus. So
great. And I would add that Patrick talked about, well, great 2030 goal, but is there a 2026 or 2025 version? We can add to that too. And I do want to turn more specifically to how to get from here to there. But before we do that, another key component of this overall strategy, besides getting to comprehensive person-centered care for everyone, was really around health equity. We've seen, as you mentioned, the pandemic, the disparities were there before. Maybe they're clearer, more obvious, and even larger now, but certainly a key feature of the way that health and healthcare are distributed around our country, and also a central part of this refresh strategy.
100%. The equity is been key to the entire administration, to be clear, right? Even more beyond health equity broadly, and culturally an area we are, but so gratifying to be able to shine a light in this area and really give it the time that it's due. And so definitely making that a focus. And certainly I think we've spoken in other areas about how we're looking at what we can do in the model space, wearing a CMMI hat, in terms of collecting more data, thinking through what the appropriate data collection is. There's certainly been some wonderful forerunners in this space that have looked to standardize. So looking to pull that up. I think in the home care space, equity is really important. It's interesting because sometimes we have the conversation about whether it's okay to think about serving underserved populations in areas where we don't have potentially good housing, right? Like, how are we going to get into the home care space if we're struggling about housing? And I think that speaks to the entire person-centered focus that we're trying to bring in that strategy, in terms of getting broader than just the medical care, that singular focus. But as several of our models are doing, what kind of food insecurity is there? What kind of housing needs are there? And so I think looking to provide care in the home, which can be very broad, I think also looking at that whole person-centered care and making sure that we're picking up all of the pieces so that there's equitable ability to get the wonderful care that can be furnished in the home, and we know can be clinically, emotionally, spiritually so much better for people.
Yeah, great points. I appreciate your bringing up the importance of those social factors that influence the health outcomes too, and how much attention's being directed to that part of comprehensive care as well. So I would like to get a little bit more into the payment reform aspects of this, and where you're focusing a lot of your work is it's pretty much seemed to be a universal view on the previous panel, and you talked about inverting the triangle. It's going to be very hard to achieve these goals around comprehensive care at home, if that's where people want it, around achieving greater equity without making real progress on value-based payment reforms. But at the same time, we've got now a decade of experience under CMMI, longer experience with different types of demonstration programs and payment pilots, including in the home care space. And I want to get in a few minutes to what you've learned from that decade of experience. I know that's part of the refresh. You're getting a lot of input from the broader community about that too. But just to frame the value-based payment approach in this space, so patient-centered, person-centered care for beneficiaries with complex needs, especially at home. There have been a number of programs, and you heard on the previous panel some different views about joiners versus splitters, or I'm going to lose everybody, I think, on this reference, but Isaiah Berlin talking about the hedgehog and the one big thing versus the fox and the pieces coming together. What do you see as the picture emerging in this space, or is that still something we're learning about? For example, are more advanced comprehensive payment reforms like Patrick Conway was talking about, that exists now in Medicare Advantage, that could be expanded in duals integrated plans in SNP plans, so-called special needs plans, or more comprehensive models on the traditional Medicare side, direct contracting, something that pushes the ACO models further, something comprehensive like that versus maybe a stronger primary care model, primary care first, physician-led ACOs coupled with other kinds of expanded episode or condition or broader programs like you've been working on in your group over the past few years. Maybe just some big picture, Chris, your thoughts now on what the best directions for achieving this kind of goal through payment reform would be.
I was going to say, those are three great approaches. You're hired, Dr. I think that I don't think that there's I personally do not think that there is a strong single approach. I think that to get here, we need to have flexibilities in many places. And I think to meet patients where they are, we have to have flexibilities in many patients. To promote getting into more home space, it has to be something that's more accessible and understandable to providers in a lot of different ways. And we also know that the more that we see providers understanding the availability of home care across a broader patient population, the more able they are to be able to make it available. And so I would say that those are three great ways you should continue to focus in that area. I think what we would be thinking would be, how can we the key point behind home-based care is the flexibility. The key point behind all value care is to provide more flexibility to allow physicians to really deliver care the way they want to, so that patients who are coming into that process are empowered to get the care that they need in a way that meets their needs. And trying to sort of pull out some of the brick and mortar that is getting cemented in place with fee-for-service. What fee-for-service does is solidify at a point in time a particular process or idea, and then it leaves it there. And it builds slowly over time. And I think trying to figure out how to pull some of that out and create the flexibility for the physician at that level, at many different levels, to invert the triangle makes sense. And so we would be looking at those home-based flexibilities as something that could be offered in a lot of places, to allow as benefit enhancements or additional flexibilities or opportunities to go into the home, however we do it, in order to allow folks to take advantage of it, and to not necessarily look at it as something that has to be brick and mortared into the current system.
Yeah, maybe just to pick up on that really critical point about flexibility, just looking at the Q&As that we've gotten from a lot of the people who are joining us today. Many of them go to issues around what gets covered, what doesn't, and to your point, Chris, more flexibility seems good to tailor the services and supports to what a particular patient needs. On the other hand, as I used to say in these models, right, more flexibility is great, but along with that, we also need to expect maybe more accountability, that if new kinds of services are being covered or delivered, are they really delivering what matters the most to patients? And also keeping an eye, I know you said it's not just about cost, this is about transforming our healthcare system, but we do need to think about sustainability of these models from a financial standpoint. So along with the flexibility, any thoughts about how these alternative approaches to get to more person-centered care could also pay attention to what may be needed for greater accountability and confidence that the models are actually achieving their intended goals?
Yeah. And I think that gets into kind of where is the science of being able to look at those outcomes within these total cost of care frameworks. Because what you really want to be able to do is offer the flexibility and offer sufficient financial support without, and that's the fine line to be walked, right? Without kind of going too far or doing too much, doing too little. Finding the sweet spot in terms of that total cost of care framework that for the resources allows the flexibility. And then as always, how do we make sure that we're getting the outcomes that we need? And I know that we certainly have been looking at the patient reported outcomes, really hoping that the science that we can get to kind of what that patient that embraced Patrick when he arrived, what is their experience? Where did they have the hiccups? How did we capture it in a way that made a lot of sense so that we can feed that back up? That's the missing part to put on the economist hat. That's the missing part of the price signal, right? In the healthcare space, that experiential factor that can never be had. So getting that prom and tying it to the outcomes in a way that makes so much sense to patients is important. And I'm sure there's advances further to be made in terms of additional outcome measures that we could look at, but definitively, it is an entirely different paradigm for thinking about how care delivers. And sometimes it's less comfortable when you're trying to leave fee for service and move into something else. So we hope that those flexibilities feel supportive and it's enticing enough and supported enough, and that everyone who goes into medicine wants to deliver care in a way that they thought about when they started practicing, and can we recreate that experience in a way with these flexibilities that will allow folks to get there?
Yeah, it's a great framing, and you've touched on a bit of this already, but I wanted to dive a little bit deeper too into what you see as some of the lessons from the experience with all of these payment reforms. Again, you've been living through leading many of them and being right on the front lines of getting through these challenges in practice of helping meeting providers and people where they are, and helping to step up with what sometimes may be uncomfortable or challenging process of developing new capabilities and being accountable for more than just billing for a service, but really being accountable for these actual ultimate goals. So 50 plus models at CMMI over the last decade. Among the lessons that CMS, I think, feels are important coming out of that experience is that, this was maybe great when we were starting out, but we need to streamline. There are some lessons and findings that have come out of these. Maybe one is that lots and lots of models, while important for piloting, may make it challenging to get to transformational reforms. Maybe another lesson that some of these models take time, and especially if we want bigger changes in these capabilities and comfort and capacity for success. Things that were emphasized in the last panel, like timely data sharing being important. Any thoughts that you'd like to add, particularly for this complex home care population that would resonate with the lessons that you're seeing coming out of the experience to date, and how that's informing where you're headed from here?
Oh, there are so many. I mean, I think overall, one thing I would say generally is that moving to value-based care, which I think many of us here would firmly believe, like, we have to get there, or what do we have left? Really moves at the speed of trust. It's one thing to know if you do a service, you get a payment. It's another thing to know that you're going to be held accountable. And so at a most basic level, what we know from doing this is that things work best. People feel, providers can get out there, patients feel encouraged when they're working in a supported environment and they're not on the defensive all the time. And while that may seem odd, I think some of the most fantastic practice transformation that we've seen broadly, particularly in this complex care space, has come when there's a belief in getting to where we're going, and there's a commitment to making that happen. But that has to happen with all of the things we just talked about. I can't be flying blind. I need data and technology. I need to make sure there's enough run room and time that I can make changes, and I feel like there's some supports there if things don't quite go my way. And generally speaking, I have to feel like the rug's not going to be pulled out at any given point in time, because I'm putting myself out there. And so even though that feels a little organizational, behavioral, I think that's really, really true. I think that beyond that, a lot of times the clinicians take it all on themselves. Once they get moving, they're really going. And a lot of the innovations that we have, once we say you really need a 24/7 line, well, all of a sudden it's a 24/7 line and the navigator, and someone calls, and all of those things kind of run on their own. So I think what we need to do is build the infrastructure. I don't think we need to be necessarily in the day-to-day of the care, but we need to make sure that we've got good payment, good risk adjustment, good data, all of those things coming along, good quality outcomes in a way that isn't sort of tied to some of those individual process measures we started with back in 1990, and continuing to make that go forward, but in an environment where people really feel like they can make the step.
Yeah, and that may be easier with these, not only the clear long-term goals that you've laid out, but as continuing to clarify the pathway to get from here to there, meaning it's less about what a particular model is right now, and more about we're going to continue to iterate models and continue to advance as the capabilities in the health system do as well, and as the experience helps us refine these steps. I think that means, though, heading towards maybe a more, I mentioned streamlined earlier, but smaller numbers of models. And maybe if you could say a little bit more about that. And I do want to push you, since we've gotten a few more comments on this, about, we talked about 3 big ways maybe to get there. One through Medicare Advantage and duals, fully integrated SNP plans or similar, Medicare Medicaid integration on the health plan side with accountability. We talked about direct contracting and sort of all in ACOs, maybe moving farther from fee for service. We also talked about models that could work with primary care practices in concert with other kinds of care providers, who also, I think, at least my view is that they need models that aren't fee for service too, to help the specialists and the hospitals and so forth work with these models as well. So maybe you could say a little bit more about what this future structure might look like. And if you don't have all the answers, that's great. But an alternative, Chris, might be asking this group, where do you need some more input, support for clarifying the path from here to there? So
I think everybody knows we don't have all the answers, because if we had all the answers, we wouldn't need to have a panel. We would be done, and that would be great. I think that the current vision is, I think the first 10 years of the Innovation Center, and we've certainly talked about this, was a lot of proof of concept testing. We talked about it, and then really there was an opportunity on a grand scale to say, okay, does it really work? Can we really do something else? And that was really critical as part of any research process, to understand like what we could do. I think where the center is now, current leadership is saying, okay, we're firing on 5 million fronts. People are getting some different messages, or they don't know where to go. They're not quite sure how it fits together. Can we please take all of the different streams that are moving and create, and that's what the vision is, create something that allows people to really see the future in a way that allows for more commitment, more investment. It's not opaque. There's a path forward. So I think that was the intent in terms of streamlining the models. what's been very difficult, I would say conceptually for us, is that we're trying to wrap our hands around the entire healthcare system, which, as everybody knows, is a little bit challenging. And so once you try and think through, okay, where does primary care go? Where do the specialists go? How do they come together? I mean, before we were working in a little bit of a silo, and now that integration, I will say we've had our own growing pains internally trying to figure out, well, wait a minute, how do I get what I'm doing over here to fit in with what you're doing over here in a way that is very concretely down on the ground, sending exactly the same signals to everybody at the same time. And that has proven challenging. So it's like we will see a streamlined number of models, but with more scope, right? Because if you're talking about trying to create something that covers a good swath of the healthcare system, you've got to be able to have that advanced primary care. You be able to value care in your specialty space. You need to have an opportunity for people to walk into more accountability. And it's not that it's fewer models maybe, but with a broader scope. And so I think you're right. We definitely have been looking at what to do in MA. Primary care is a primary focus that is clear from the strategy, and we've been spending a lot of time on that, into the underserved population, thinking through what the next version of ACOs looks like, and how we get to that. And then even more importantly, how can specialty care really feel like they are part of this process? I think sometimes they've often felt like they're not part of this process. So how do we get it to a point where the incentives for them align and they can nest right into some of these pieces? But I don't know that we know explicitly. I think that's the most tenuous scaffolding that we're trying to work from. And I think all of the folks here know more than I do about specifically how it's supposed to come together. And I think it has to continue to be a discourse that we build it as we go. I don't know if I answered your question, but
no, I think it's a great answer, and it's a good challenge for all of us who are with you today, including us at Duke Margolis and not me, but our team that actually does all the real work, but all of us at Duke Margolis and our collaborators who certainly share the goal, but I think also need to appreciate the challenges of taking all these pieces, as you said, in this whole healthcare system and finding an effective path forward to put it together. So challenge I think accepted from the group here. Before we wrap up though, I would like to tie us back into, as you mentioned at the outset too, and others have throughout the meeting, we are hopefully entering a new phase of the COVID-19 pandemic, one where COVID certainly isn't gone, but maybe is more manageable if we take some further steps to continue to contain it. If in the pandemic, there were a lot of regulatory flexibilities implemented, site of service flexibility, provider licensing, and other types of flexibility that absolutely had the effect of promoting more care at home. And there's been some discussion during this session. I think a lot of organizations like to continue that flexibility, but there have also been some concerns raised about does this lead to maybe inappropriate billing? And some actuarial estimates suggest that just continuing some of these, say, site of service, site neutral payments could add to costs over time or create some other challenges. Can you say a little bit about how you're thinking about, since you've done it in some of your previous models, having more flexibilities built into the pathway to implementing and supporting some of the payment reforms?
Yeah, absolutely. Well, so I think at the highest level, of course, folks know that the agency itself has certainly looked to see what makes sense, where it has flexibility to continue some of the most basic, like for example, in the telehealth space where there's some services that can be added. But broadly, of course, much of what was done through waivers. And so the place that makes a lot of sense is to think about whether they can come through flexibilities in the Innovation Center, because otherwise they will require statutory changes. And so you're right, we created the Hospital Without Walls program for the COVID-19 pandemic, which allowed for outpatient hospital visits into the home and billing as a hospital. It allowed for, ultimately became the Acute Care at Home program that's running under waivers through our quality center and is allowing for hospital care in the home. I think we are, and particularly in the hospital at home case, I mean, clinically, you cannot argue with the outcomes that we observe there. And that has been true for a long time. I think there's a long history literature in that space that continues to show that it's useful. I think where we have struggled some is, were we to try and think about it again, cementing it into the fee-for-service system, it's not at all clear that that would be the best place to do something with it. And so I think we've really been thinking about it again in the scope of taking on accountability for a population. You should be able to have all the flexibilities available to you. And so we are looking very closely at that at-home care, particularly hospital at home. Certainly the current direct contracting model does waive the homebound requirement to allow more care to be furnished in the home broadly at the physician's discretion. I think a lot of the telehealth flexibilities and virtual care that we've talked about, again, that flexibility to use all of those tools, assuming we are monitoring safety appropriately, furnishing that in the home, if that's the right place to do it. I think that is really how we're thinking about looking at all of these, and that fits squarely within the refresh. I think the refresh strategy has been very clear. We're really looking to get everyone to accountable care. And what that means is really offering those flexibilities under that umbrella of accountable care and really in that space. And so I think we're looking at all those flexibilities and saying, okay, we're really going to move them. And so, you know, we've talked about what the waivers would be, for example, for a hospital at home, and continue to look at those. And I suspect that's where we'll continue to be, but very open if folks have other ideas there.
Chris, I want to thank you not only for some thorough and thoughtful answers to some really challenging but really critical questions related to where we go from here around advancing home-based care as a key part of achieving the CMS vision of comprehensive care that's truly person-centered for everyone in the Medicare and Medicaid programs. I know we've gone a little bit over on your time, so thanks again for joining us. Thanks again for laying out challenges for all of us to help achieve these critical but very challenging goals. And please get back to work. We appreciate it. So before we wrap up, I just want to say a few final words to all of you who have joined us today. The main word is thank you for taking the time and effort to be with us. This is such a critical set of issues. And despite all of the hard work by so many people who have been engaged in reforms around home care delivery and how to support it, all at the person level, we clearly still have a long way to go. But the good news is there are both clear examples of paths forward. We heard about many of them today, both to provide more comprehensive, effective care and efficient care at home, and to address equity in the process by delivering a person's care needs for an individual more effectively at home. We can reduce costs. We can open up opportunities to bring in community supports and other supports for addressing the social factors that are so important in improving equity for all Medicare and Medicaid beneficiaries, but particularly for those with special needs and limited means at home. And we've seen some real opportunities both from the payment reform efforts over the past decade plus and the COVID-19 public health emergency and the responses to it to build out these models. And I think from the remarks that Chris gave, I think it couldn't be more clear that now is a great time to come together, find the best path forward to build on these approaches. I'm just going to paraphrase one of the Q&A comments, which is, this stuff is hard, figuring out how to come up with the better care models and support them through payment reform and the different kinds of pathways that we've talked about today. But what's really hard is actually being a caregiver or someone who's living or trying to live at home with healthcare that just hasn't come together yet around their needs. So as we keep all that in mind and think about ways to move forward with new models at CMMI, with new steps in Medicare Advantage and collaboration between state initiatives and CMS initiatives, with all the good ideas coming from the many diverse stakeholders who care about these issues. I hope we'll keep all of that in mind and reminder about just how urgent and important this work is. So thanks again to all of you. Special thanks to the John A. Hartford Foundation, Ronny and her colleagues, the SCAN Foundation, Gretchen and the team there, the Commonwealth Fund with Karin and the great team at Commonwealth, and then a special thanks to the Duke Margolis team that is making all of this possible. Jonathan Gonzalez-Smith, Will Blesser, Montgomery Smith, Luke DeRocher, Rob Saunders, and the rest of us. I'm sure I'm leaving out someone. We look forward to continuing to work with you all on meeting these critical challenges for the well-being of some of Americans who need the most help. Take care and have a good rest of the day.